Nasal obstruction is a common complaint among patients seen by internists. Most of these patients will have minor problems, but the rare patient will have an extremely serious disease that requires prompt diagnosis and treatment. Of these extremely serious diseases, the one which is unique to nose is sinonasal malignancies. Although the sinonasal malignancies constitute less than 1% of all the neoplasms, among the sinonasal malignancy, the malignancy related to maxilla happens in 55% of cases. Okay, so that is the importance of CA maxilla, and also most of these malignancy maxillas are misdiagnosed as rhinosinusitis at an earlier stage, and when we diagnose it as malignancy, it becomes in an advanced stage. So that means the average time delay or an interval between the first symptom and the diagnosis of CA maxilla is around 6 months. So that is the importance of knowing about CA maxilla. So today I'll explain or discuss on Carcinoma Maxilla. As long lectures are very boring to many of us, including myself, I will split this into 2 sessions, and in the next 15 to 20 minutes I will explain about CA maxilla, its etiology, then the clinical features, and also the investigations and how we can come to a diagnosis, including staging of CA maxilla. And in the next class I will explain the various types of maxillectomy. So what are the causes of this malignancy or CA maxilla? Causes. Invariably, it is something which is related to inhalation of carcinogens, isn't it? Because we are inhaling through the nose, this can go to paranasal sinus. The most important cause of the CA maxilla is inhalation of carcinogens. Of that, the wood is very important. Wood, okay. And among the wood, the type of wood is again important. Can be either a hard wood or it can be a soft wood. This hard wood is commonly used in furniture industry. So, and among the hardwood, the African mahogany is the most notorious for development of this carcinoma maxilla. African mahogany, okay. And this hardwood is mostly related to adenocarcinoma. And softwood is related to development of squamous cell carcinoma. Okay. Biologically active compounds in this hardwood will impair the mucociliary clearance, and that may be a factor which is contributing to development of carcinoma. And the maximum number of upper jaw carcinoma in the world is seen in Bantu tribes of Africa. Okay. It is seen that this group of tribes are burning this African mahogany for their domestic purpose, cooking purpose. Okay, so a relation is seen, a high relation or association is seen between this African mahogany and development of CA maxilla. These are other causes. The second, exposure to nickel, then smoking. Those who smoke while burning or cooking with the African mahogany, they are really gone, because this smoking has got a synergistic effect with the, or an added effect with the hardwood. Okay. So that's why I told it's a deadly combination of smoking and cooking by burning African mahogany. Then exposure to chromium, then polycyclic hydrocarbons. Aflatoxins, mustard gas, thorotrust, And along with this, you can also add exposure to radiation, viral particles, and also genetic causes. So 5 is exposure to radiation to other parts, or an hazardous radiation exposure, then viral and also genetic causes. So these are the etiology or causes of carcinoma maxilla. So because of any one of the above mentioned reason, a focus or a seed was inserted or put into the maxillary sinus, and now comes the clinical features. So next is how it manifests or the clinical presentation. If you know the surgical anatomy of maxilla, this spread and clinical features will be very easy. I have already explained anatomy of CA maxilla in the previous class, so please go through that before coming to this video. Okay, anyway, I will explain this with the skull and the individual bone. So you can see this, here comes the maxilla, and it has got a very close relation with the orbit, then with the palate or the oral cavity, then the nose and the middle cranial fossa. See, it goes posteriorly, and here comes the middle cranial fossa also. Okay, left maxilla, and you can see the maxillary sinus inside. So there is a space inside. So that is why the earlier stages of CA maxilla remain silent, because there is a space for it to expand. And once it fills the maxillary sinus, it comes out with the clinical presentation. And if the patient comes to this stage, in the early stage, then there is a high chance that it can be misdiagnosed as chronic or an acute rhinosinusitis. So this tumor can breach the boundaries of maxilla and enter into the adjacent structures, either by direct invasion or destruction of the bone and soft tissue boundary, or it can also go through the pre-existing anatomical pathways. See, like the intraorbital foramen or fissures, etc. So I'll explain what are they. You can see here, as it has got a very close relation with the orbit, with the nasal cavity, with the palate or the oral cavity, and also posteriorly with the pterygopalatine fossa, and also with the infratemporal fossa, and also it can go superiorly to the middle cranial fossa. Okay. An extension into the nasal cavity can be manifested by either our usual clinical features. Once there is a mass in the nose, it can present as nasal obstruction, or it can present as epistaxis or bleeding from the nose. Okay, and also if it touches or presses the nasolacrimal duct, the presentation can be epiphora, that is watering from the eyes. So nasal presentation can be either nasal block, or it can be a bleeding from the nose, or it can be epiphora. Okay. And second, superior, if it is going superiorly, it can lead to invasion of the orbit. So what will happen? This may manifest as ocular pain, eye pain, or it can be a fullness in the eyelid, or there can be a unilateral epiphora, again watering from the eyes, or there can be extraocular. If it is going to the extraocular muscles, what will happen? It may be limitation of the movement of the extraocular muscle, or the patient will complain of double vision or diplopia, or if it is pushing the contents outward, it can present as proptosis also. Okay, so what will be, if there is invasion into the orbit manifesting as ocular pain or fullness of the eyelids, or a unilateral epiphora, or if there is involvement of the extraocular muscles, there will be limitation of movement or diplopia, or there can be proptosis. Okay. And here comes the intraorbital foramen, and the second division of trigeminal nerve passes through this. So if the nerve is involved, or there is compression of the nerve, there can be numbness of the cheek area also. Okay. And then floor of maxillary sinus, here, this part. Floor of the maxillary sinus corresponds to hard palate of the oral cavity. So if the tumor extends to this area, what all things can happen? If downward extension or palatal involvement, there can be pain, there can be malocclusion, there can be loose dentition, or if the patient is using dentures, it can go to an ill-fitting dentures, or there can be a bulge in the palate called palatal fullness, or it can be ulceration also. Okay, then what will happen? It goes anteriorly, coming anteriorly. Anteriorly, extension can breach the anterior wall of the sinus. So what is outside the anterior wall? There is soft tissue and then comes the skin, isn't it? So this can present as skin lesions, or there can be a lid edema, and that is called what? Peau d'orange, isn't it? So lymphedema or skin lesions or fixation of skin over the maxilla, all this can happen. So if the skin and soft tissues are involved, it can lead to skin lesions or fixation of the skin over the maxilla, or can be lymphedema also. Into the orbit, medially into the nasal cavity, anteriorly into the skin and subcutaneous tissue, and downwards into the or inferiorly into the hard palate. And the most important part is when it goes posteriorly. Posteriorly, the important area is a pterygopalatine fossa. Here comes a pterygopalatine fossa, and here comes the infratemporal fossa. And this pterygopalatine and infratemporal fossa are densely populated by muscles of mastication, the pterygoid muscles, various sensory and motor nerves, and by carotids and other blood vessels that supply the nasal cavity, oral cavity, the maxillary teeth, and also the pharynx. So this area, involvement of the posterior part is will lead to serious complications. Okay, so tumor extension, if it is going into the posterior involvement, will lead to trismus, or difficulty in opening mouth, because of involvement of either the pterygoid muscle or motor branches of mandibular division or trigeminal nerve. Okay, mainly the trismus is due to involvement of the pterygoid muscles. There can be pain in the maxillary dentition because of involvement of anterior, middle or posterior superior alveolar nerve, which are branches of maxillary division of trigeminal nerve. It comes in the posterior part. Okay, or it can be severe epistaxis. How? When involvement of terminal branches of internal maxillary artery. The maxillary artery is there in the pterygopalatine fossa. So if there is involvement of the branches of the internal maxillary artery, the patient can present with the severe epistaxis. Okay, so the posterior spread is a much more tricky and also dangerous area, and also this pterygopalatine and infratemporal fossa are potential route of spread into intracranial tumors. Okay, so either it can go directly to the middle cranial fossa, or through preformed pathways or hematogenous spread can occur. So intracranial involvement, if there, what will happen? It increases the risk of middle cranial fossa is an area where it gets involved. So there can be spontaneous or postoperative CSF leak, meningitis, or there can be chance of intracranial abscess also. And the other important structures which comes in the posterior part, what are they? One is eustachian tube. That is why this CA maxilla can present as secretory otitis media. Okay, so secretory otitis media, decreased hearing, and also otalgia, referred earache, referred otalgia can occur. So when there is posterior spread and involvement of the eustachian tube, it can present as a conductive hearing loss or secondary serous otitis media, and also as a earache. Okay. The next is patterns of tumor spread. It can be either local spread, or it can be regional spread, or it can be distant metastasis. So coming to the local spread, usually this maxillary sinus growth will first fill the sinus cavity. So at that time this periosteum then the perichondrium and also dura will act as local barriers to the spread of malignancy. But as the orbital and the medial wall, the superior wall and the superior wall and the medial wall of maxilla are very thin, this usually will destroy the bone of that areas and will go on spread, local spread will occur. And only 25% of the cases are contained within the sinus cavity at the time of diagnosis of CM maxilla. 75% of cases will present with the spread beyond the maxillary sinus cavity. Okay, so I already explained about the spread. The local spread can occur, superiorly it can occur into the orbit, medially it can occur into the nasal cavity, inferiorly to the palate and into the oral cavity. Posteriorly, it can go to the pterygopalatine fossa, intratemporal fossa, temporal bone, and then into the middle cranial fossa. Then anteriorly into the skin and soft tissue, and laterally it can go to the skin and also to the intratemporal fossa. And what about the regional spread? Regional spread, that is the lymphatic metastasis, spread through lymphatics. And before going to that, you have to remember one thing which is called the Orngren's line. What is this line? Orngren's line is a line passing through the medial canthus of eye to ipsilateral angle of mandible. In this, it will go from the medial canthus of eye to the angle of mandible. So, the line will pass like this. Okay. Line will pass like this, and there will be an andro-inferior part and there will be a postero-superior part. Okay, so these andro-inferior malignancies have got a better prognosis and they are more amenable to treatment, whereas the postero-superior malignancies are more aggressive with a poor prognosis. Okay, and also they are poorly differentiated malignancies. So andro-inferior part to the Orngren's line has got a better prognosis, and the postero-superior one have got a poor prognosis. Okay, so this lymphatics are also divided according to this Orngren's line. Those from the andro-inferior part will drain first to the jugulo-digastric, then to facial, parotid, and to submandibular. Okay, so this jugulo-digastric and submandibular lymph nodes are the most commonly affected lymph nodes in the case of CM maxilla. This is usually asked as MCQs also. And from the postero-superior part, it go to retropharyngeal lymph nodes. And from both these, the second into lymph nodes along the upper jugular chain. Okay. I explained the lymphatics of head and neck in a previous class. Please go through that. Then there won't be any confusion regarding the placement of this jugular chain. So, jugulo-digastric and submandibular in case of andro-inferior, then retropharyngeal in case of posterior, and finally they go to lymph nodes along the upper jugular chain. And this distant metastasis is usually unusual, but it occurs in 18% of cases along with if at all with adenocarcinoma, and in 10% of cases of squamous cell carcinoma. And usually it occurs to which all areas? It can happen to bone, then can happen to brain, liver, lung, and skin. Okay, so distal metastasis is usually unusual presentation of the CM maxilla. If at all happens, it is more with adenocarcinoma and less with squamous cell carcinoma. And the sites are bone, brain, liver, lung, and skin. And usually it becomes a inoperable and advanced stage of CM maxilla. Next is staging of CM maxilla. So as for all staging, TX is primary, cannot be assessed, and TIS is carcinoma in situ. And T1 to T4, T4 again divided into T4A and T4B. So T1 is limited to sinus mucosa. Inside the sinus, there is no bone erosion or destruction of the bone. Okay. And T2, from T2 onwards, there is involvement of bone erosion or destruction is there. But in T1, there is no bone involvement. Okay. So T1 is limited to sinus mucosa without bone destruction or bone erosion. And T2 is involvement of hard palate. From T2 there is bone destruction or bone erosion and involvement of hard palate or the nasal mucosa, but there is no involvement of the posterior wall of maxillary sinus, or there is no involvement of the pterygoid plates. And in T3 there is involvement of any one of the following. That is skin, subcutaneous tissue, then you can see the orbit, only the floor or the medial wall of orbit. So along with medial wall there comes ethmoid sinus also. See, so orbit, ethmoid sinus, and also there is involvement of the posterior antral wall and also the pterygoid plates. So that becomes T3. So involvement of the skin, subcutaneous tissue, the floor of orbit, medial wall of orbit, ethmoid sinus, and also the posterior wall along with the pterygoid plate. So any one of the following involvement, it becomes T3. And T4A is moderately advanced local disease. Moderately advanced, and T4B is very advanced. Okay, so T4A, the difference is orbital contents are involved, but only the anterior orbital contents. And when the orbital apex is involved, it becomes T4B. So in T4A, skin of cheek, orbital content, then the pterygoid plate, infratemporal fossa, then the cribriform plate, then the frontal sinus, and also the sphenoid sinus. But ethmoid sinus involvement is T3. When the sphenoid or the frontal sinus involvement along with cribriform plate and also the orbital content, it becomes T4A. And when the orbital apex is involved, that is posterior involvement of the orbital content, it becomes T4B along with dura, brain, cranial nerve. And for the cranial nerve, except maxillary division of trigeminal, infraorbital nerve involvement can be included along with the T3. Okay, so T4B is cranial nerve involvement except second division or maxillary division of trigeminal. Okay, and the nasopharynx and clivus involvement, all these become T4B. So this you have to study. This is usually asked in exams and also very important for planning of treatment of carcinoma maxilla. Coming to the staging matrix, that is TNM staging matrix. The N staging is similar to all other malignancies, and it was described along with the staging of malignancy larynx. Please go through that. And here stage 0 is TIS N0 M0, and stage 1 is T1 N0 M0. T2, stage 2 is T2 N0 M0. Okay, T2. And stage 3 is T1 or 2 and N1 and M0. When it becomes N1, it becomes stage 3. Okay. And when it becomes N2, it becomes stage 4A. So T1 or T2 or T3 with N2 and M0 is stage 4A, or it can be a T4A with N0 or N1 or N2 with M0. And when it becomes M1, it becomes stage 4-3. That is the most advanced stage. In M1, any T or any N, but if it is distant metastasis, it becomes stage 4C. And stage 4B is T4B, any N M0 or any T N3. If it becomes N3, it becomes stage 4B. That is, you can remember it easily like that. If there is distant metastasis, it becomes stage 4C. And if there is involvement of N3 stage nodal spread, it becomes stage 4B. Okay. So, staging matrix is very important for decision on treatment plan. For confirmation of your diagnosis, the investigations are most important. So, the most important among the investigation is one is endoscopy. So, So in the office setting itself, you do an diagnostic nasal endoscopy, and in suspicious cases, it is better to go with both flexible and also the rigid scopes. Use both flexible as well as rigid scopes to get view of all the areas inside the nose, especially you see the maxillary middle meatus area and also the inferior meatal area. So use both flexible and also the rigid scopes. And even if you are highly tempted to get an biopsy, don't go for biopsy from the suspected malignancy site in an office setting, because it will lead to non-diagnostic or misleading diagnosis. So after, if you have a doubt by doing an endoscopy, the next investigation you must do is an imaging. Okay, second is imaging. Even if you are tempted to get an biopsy, don't do that, but do it only after doing an imaging. And after imaging, both CT and MRI is needed for a complete diagnosis and staging of CA maxilla. And in the CT scan, you have to go for both high resolution CT scan, and also the bone windows should be there in both axial, coronal and sagittal cut. Okay, and of course the soft tissue details will be seen better in MRI, and in MRI, go for gadolinium enhanced MRI cuts. And this gadolinium enhanced imaging will give you more details on vascularity, dural and cerebral infiltration, and accurate assessment of orbital invasion. But that in T2 images you can differentiate between a retained secretion, tumor and also mucosal thickening. This differentiation, especially this how to differentiate between retained secretion, tumor and mucosal thickening, is usually asked in Viva. So that is by doing a T2 weighted images in MRI. Okay, and also you can do an arteriography. And this arteriography is needed if you suspect a very highly vascular tumors like an hemangioma, hemangiopericytoma. Okay, highly vascular tumors, you can go for a preoperative embolization. In that cases, go with an arteriography, and biopsy is a gold standard in the diagnosis of CA maxilla, and always try to get it through the nose. Don't go for a cadwell-like approach, because there is chance of seeding in the cheek flap, and that will makes the later resection of the maxilla difficult. Okay, so in biopsy, as far as possible, avoid taking biopsy through a cadwell-like approach, right? So biopsy is a gold standard in the diagnosis of CA maxilla. So the histopathology result came in favor of an carcinoma maxilla, and by imaging you did an accurate staging also. Then how will you proceed, or what is the treatment options? Regarding treatment of CA maxilla, the treatment depends upon the staging of the disease and consent of the patient. So in the general principle, you have to think of two things, that is accurate staging and informed consent. Especially for stages 4, B and C, and if associated with distant metastasis, the treatment is only for a palliative purpose. So we can divide that into treatment to curative and palliative. For palliative treatment, we give local debulking along with a postoperative RT. Okay, adjunctive radiotherapy. local debulking and radiotherapy, that is adjunctive radiotherapy for palliative treatment. And for curative care, we go for surgery plus post-op RT. The usual answer we get from students is a sandwich therapy, which consists of pre-op RT, surgery and post-op RT. But it's a matter of debate nowadays. So many of them tell it as pre-op RT will interfere with the post-operative healing, and especially with the modern day very precise high definition radiotherapy techniques, it is better to say as the curative treatment consists of surgery with the post-op RT. And is there any role of chemo? And also this post-op RT is especially good in case of slow-growing tumors like a chondrosarcoma or an adenoid cystic carcinoma. And what is the role of chemotherapy? Chemotherapy has no role in case of squamous cell carcinoma or adenocarcinoma, but it is useful in olfactory neuroblastoma, rhabdomyosarcoma, lymphomas, and sinonasal undifferentiated carcinoma and cystic carcinomas of the ethmoid sinus. So mainly the treatment options are surgery and post-operative RT, and if at all using chemotherapy, it is basically 5-fluorouracil, and the topical application is found to be much beneficial in so many evidence-based studies. Okay, so this is regarding the treatment. Anyway, an accurate staging is very important to decide treatment and also consent of the patient. And contraindication for surgery. The definitive contraindications are poor health and the patient not willing to do surgery. These are the two absolute contraindications. Patient not willing for surgery and also poor health. Many of the textbooks tell it as the late stage of disease and also involvement of the skull base, also involvement of skull base and anterior cranial fossa. But the later edition, the newer editions of Scott Brown tell it as they are not an absolute contraindication because of very good prosthetic availability of very good oral processes and also the advancement in surgical techniques. So the contraindication for surgery, absolute contraindications are patient not willing, patient willingness and also poor health. Okay, and the staging of disease you can tell it under relative contraindications. So that is regarding CA maxilla. We explained about the causes, the clinical features, the pattern of spread, then the staging, how to diagnose and what are the treatment options. Now I'll explain regarding the different types of maxillectomy.